Hi, I'm Jessica Titus. I'm one of the vascular surgeons with Minneapolis Heart. I'm presenting today on aortoiliac occlusions. I'd like to thank the CVI organization for the opportunity to present. I have no disclosures. I was asked to present on this topic last year as well, and wanted to pick a new case for this year. So this one isn't exactly that I would have done anything different. However, I think it highlights some of the pitfalls when approaching aortoiliac occlusions from an endovascular perspective. So this is a 64-year-old male who presented to us with left lower extremity wounds and rest pain. Has quite a complicated history, and it's notable that most of his previous care was at other institutions, and in particular in 2014 he was treated at a facility that did not have vascular surgical coverage, which I think influenced his ultimate care. He presented there with left leg claudication, was found to have an occluded left external iliac along with a common femoral artery stenosis. Angiogram was performed with recanalization and eventual atherectomy of the external common and SFA with stenting of the external iliac. This was complicated by dissection, resulting in the loss of the origin of the internal iliac, and the flap extended into the common femoral and SFA. The profunda filled retrograde from a fenestration in the SFA and did come off the false lumen. Good flow was maintained distally, so this was decided to be managed non-operatively. He actually, at least by the records, did well until 2018 when he presented with right-sided acute on chronic ischemia. He underwent a right femoral exploration, endarterectomy, and thromboembolectomy along with stenting for a right iliac occlusion. Did well from this as well, but presented back later that year with left-sided rest pain. His CT at that time showed not much aortic disease, but a flush occlusion of the left common and common femoral with reconstitution in the SFA at that area of a dissection flap. His runoff was intact. He was taken for an angiogram and lysis. You can see the right-sided axis here. This is the initial shot with flush occlusion of the left common and no reconstitution within the pelvis. After 1 day of lysis, it cleared quite nicely. You can see there's an underlying narrowing at the origin of that stent there. This was angioplasty as it was thought to be the culprit at that time. You can see from the runoff shot, however, the persistent common femoral dissection with retrograde filling of the profunda from the false lumen. I think the decision was made that the culprit lesion was the common lesion because of the long-standing nature of that dissection flap and the fact that he had done well for so many years. However, he returned multiple times with reocclusions and unfortunately went to a variety of facilities for this and was treated in the acute phase with repetitive lysis and angioplasty. He made his way to us when he developed ischemic wounds on multiple toes on the left. And his CT at that time when he presented to my partner's clinic looked like a mirror image of his scan 2 years prior. So his operative plan was a left femoral cut down with resection of the dissection flap, realizing that this may require an interposition graft for the common femoral and a jump graft to the profunda, depending on how that dissection flap anatomy looked. then planning over-the-wire embolectomy of the left iliac thrombus with a possible right-sided cut-down versus percutaneous access, depending upon where the clot laid in relation to the aortic bifurcation and whether a stent could be placed at the very origin of the left common or if he would require kissing iliac stents. He went to the operating room. The left femoral artery was exposed. They were able to resect the thickened dissection flap and kind of recreate the femoral bifurcation, patch the common femoral. Good back bleeding was obtained from both the profunda and the SFA. The dissection flap was also resected up into the external as far as the exposure would allow. Some clot was able to be retrieved from the proximal that had a mixed acute and chronic appearance. No significant inflow was obtained, however. The patch was then accessed, and you can see here is the first picture with the left common iliac occluded. However, there did appear to be a little bit of a stump there, but concern was this area did not light up well. The over-the-wire embolectomy was performed, and the balloon kept getting hung up at the proximal portion of that stent. Therefore, balloon angioplasty was done. So at this point, the right femoral cut-down was performed. This was a redo exposure with heavy scar tissue, and so that is why it had been hoped to avoid that. If possible, he had required a wound vac to heal his groin the last time. Because of this, the common femoral was controlled proximally and distally without extending the dissection down onto the SFA and profunda. Fogarty embolectomy was performed to the right side with removal of thrombus. Good pulsatile inflow was obtained, and actually decent back bleeding from the distal common femoral was noted as well. The artery was closed primarily. And then the artery access, kissing iliac stents were placed, and drug-eluting balloon angioplasty to the left iliac in-stent stenosis. Completion picture showed a persistent narrowing of that segment of the stent. The iliacs look good, and actually the flow down the left side was much more brisk than the right, which was concerning. At that point, pulses were checked. There was good signals on the left. However, there are no signals on the right. So a shot was performed of the right groin. And you can see here that there's a profunda branch filling, but no filling of the main profunda branch or the SFA. The right common femoral dissection was then extended down to the SFA and profunda, and the artery was reopened just above the bifurcation. Fogarty embolectomy was done to the SFA and the profunda with return of thrombus and subsequent return of signals to the right foot and good filling as seen here on the angiogram. At this point, high fives were finally done right. Unfortunately, not so fast. The sheaths were removed from the patches and all of the clamps released. At this point, we did not have a great pulse in the left patch. There were no signals on the left foot now, although good signals on the right. With time, the pulse in the patch actually disappeared completely. And so the SFA and profunda were controlled once again for access and angiogram. Interestingly, once the clamps were placed back on, the pulse returned, and it was a good, strong pulse. So we knew there was some kind of ball valve physiology going on within that iliac stent lesion. At that point, we had considered using IVUS, but knew that we were going to now just stent this anyhow. The angiogram here shows no good filling. And the subsequent to retrograde shot and the antegrade shot showed us the culprit was at that area of the stent that had previously been ballooned and was no longer good through this. A Viabond was added in the left iliac. with a good result. This is a retrograde shot from the groin with very brisk filling. Finally, good PT and DP signals are now noted in both feet. Postoperatively, he did well. He had palpable pulses by the next morning. He did have some spasm in the OR, likely because of all the embolectomies, and so was not palpable leaving the OR, although had good signals. But by the next day, they were palpable. He was discharged home on postoperative day 3 on aspirin and Plavix. He stayed an additional couple days for podiatry to clean up his toes. No issues noted so far on follow-up, with AVIs of 0.91 on the right and 1.03 on the left. I think the take-home points of this case are when considering treating aortoiliac occlusive disease from an endovascular standpoint, it's important to have a protection plan for the contralateral side, especially when treating a unilateral occlusion. In embolic cases, I think taking the extra time to just dissect out the SFA and profunda can save you some headache later, as we were misled in our situation, thinking that we had good back bleeding when it was really just from a branch, and some clot had probably gone down prior to our exposure even. The role and usefulness of IVUS, especially in cases of previous stent occlusions, we did briefly consider whether our wire had gone in and out of the various stents that were already in there. I think with IVUS, we could have saved ourselves some time because we would have seen the anatomy of the in-stent stenosis and probably stented this straight out. Plus, we would have felt comfortable that we were within the stent lumen for the entirety of our course. It's always important to consider open alternatives. In this case, it would have been a fem-fem bypass or an aortofemoral bypass. I think looking at the patency rates and the operative risks, I still think this was the best direction to go for this patient. However, I think it's always important to remember that endo-hybrid is not always an easy road out, and they can become mental marathon cases, so you need to be well prepared. Thank you very much.